Hello guys, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss one of the most important skills in psychiatry department, that is mental status examination. In simple way, MSE. So for example, imagine a 24 years old man is brought to the psychiatry outpatient department by his family. They report that he has been talking to himself and laughing without any reason, sleeping very little, and claiming that strangers are monitoring him through his mobile phone. As doctors, before we label him as having schizophrenia or mania or any other psychiatric disorders, we must first answer a fundamental question, that is, what is the patient's current mental state? So, to answer that, we need very important skill, that is we have to perform a mental status examination. Just as a physician examines the cardiovascular system with a stethoscope and a surgeon examines the abdomen with inspection, palpation, percussion, and auscultation, same to same, a psychiatrist examines the patient's mind through the mental status examination. So, this mental status examination is the cornerstone of psychiatric assessment. It provides a systemic evaluation of a patient's appearance, behavior, speech, mood, thought process, and thought content, perception, cognition, and insight and judgment at a particular point in time. So, a good MSE mental status examination helps us make an accurate diagnosis, assess the severity of illness, and evaluate the risk of suicide or violence, and monitor response to treatment, and communicate finding effectively with other healthcare professionals. So remember, the important statement is history tells us what happened to the patient, but the mental status examination tells us what is happening to the patients right now. So if you're seeing here, this is the most important lecture in psychiatry department. Okay, if you are doing in right now, if you are doing any clinical rotation in psychiatry department, so this is the important topic. Why I'm telling this is important means this is the main MSE. It's like foundation of all psychiatric diagnosis, and it's like physical examination in medicine. So it will helps to differentiate schizophrenia, mood, and disorders, delirium, like different types of psychiatric pathological conditions. So it's like core skill in OPD, ward, or emergency psychiatry, or guides diagnosis and management. So this is very important in exams in OSCE settings, like long case or OSCE stations, and frequently asked in like some competitive exams like FMGE, NEET PG, and USMLE. So first of all, we have to understand what it is. Mental status examination is a structured assessment of a patient's behavior and cognitive functioning at the time of interview. So if you're seeing this notes here, I'm highlighting. So it's like systemic appraisal of appearance, behavior, and motor functioning, and overall demeanor of a person. That means, in simple language, psychiatric version of physical examination of the brain and mind. So snapshot of mental functioning are based on observation and interview, and it will change with time. So and it reflects a person's psychological functioning at a given point in time. So this MSE itself is not a disease, but widely used. So the incidence universal in psychiatric patients, and if you are seeing prevalence 100% in psychiatric evaluations, in age all age groups, if you are seeing gender equal usage, in risk groups the psychiatric patients, neurological disorders, and substance use patients. So the causes, this MSE, if you are getting that MSE is like abnormal, that means you have to understand neurotransmitter imbalance like dopamine and serotonin most commonly, and brain lesions like frontal lobe or temporal lobe, or genetic predisposition. In psychological, you can say trauma or personality disorders or stress reactions. So in social, if you are seeing many substance abuse, family conflicts, or poverty, or isolation. So these are things we can see in MSE. Okay, so mostly for doing mental status examination, we have some components. The components is very important. One is appearance, behavior, speech, mood and effect, thought process and thought content, perception, cognition, and insight and judgment. We will discuss this everything in deep, step by step. First of all, we can see here that is appearance. Appearance means what we are seeing. So, for example, like gender, it's male or female, and age, and ethnicity, and race, and body habitus, and clothing, how that cloth will be like, what are the cloths they are wearing, this everything. Then after we can see like attire. In body habitus we can see weight and height. So next we can see like grooming and dress hygiene, and distinguishing like scars, tattoos and piercing, and we can see sometimes gait and restraints. Restraints means like if patient is too much aggressive, that handcuffs or ropes or chains, or deformity like our physical abnormalities. For example, disheveled, unkept, poor hygiene. So these are the things we can see in appearance. Along with that, we can see like examples like patient comes to the OPD wearing pink shirt and orange pants and mask of the board, or goggles, hat and lots of makeup. Then we have to suspect the patient have manic symptoms. For example, when I'm doing clinical rotation, that time I saw one patient, he weighed like a total thick red font, and the board like a board mask he kept, and he came. So the doctor told, what you are suspecting? I told the patient have mania, because the guy is telling like, I came here to save every person. I am the Jesus Christ, second coming Jesus Christ, like that he told. So we have to understand, based on the patient appearance we can suspect what problem patient have. Okay, so next we can see behavior. In behavior we can see like cooperate, like the patient is cooperating with us or not. So in behavior we can divide into three different parts. We can divide and we can do assessment about behavior mental status examination. If you're seeing attitude, in attitude the patient is engaged or not. Its patient is friendly or hostile or guarded or evasive. So based on this thing we have to mention in our mental status examination. And then after eye contact, some patients are not giving appropriate eye contact. They are not giving proper eye contact, we have to mention. Then after downcasting, and some patients will avoid eye contact. Then after staring and glances. So these are the things we can see in eye contact. Next, psychomotor activity like normal, agitated, restlessness, or retarded or slowed, a tremor and pacing. So these are the behavior we can see. So in behavior it's like cooperative and agitation, and we can see eye contact. In example, we have to avoid eye contact or restless. Then we have to suspect this patient have some pathological condition based on that MSE. Okay, so next we can see here speech. In speech mostly we are focusing on rate, volume and tone. But first of all, whenever any patient is talking with us, then that time we have to focus on presence of accent. That accent, based on that accent we can understand the patient from like foreigner or the same place, same country person. Next one, fluent and amount of talkative. So we can divide the speech into three different things. One is rate. The rate will increase or it will reduce or normal. Next we can see tone. The tone will increase or reduce, or it will be like monotonous. Next we can see volume. Some patients will talk loud. Some patients will talk very like very low sound. Okay, and we can see some style. In speech, some patient will talk with pressured speech, agitated speech, slurred and mumbling and muttering. For example, if you are seeing patient means pressured speech, mostly we can see in mania. For example, patient speaks very rapidly and copious amount of not possible to interrupt. That means in mania we can see the volume will increase and the tone also will increase. So these things we can see in speech. Next we can see mood. Mood related to inward. Inward means everything will be like subjective from patient words. How it will be inward means the patient will give reply about their mood. So we have to think that is mood will be like inward. So mood means it's like patient's subjective feeling. Simple. in simple language. So if you're asking how are you doing, the patient will tell like I will feel sad, I feel sad, or I'm feeling anxious, like that they will give reply. So that is patient stated that the patient is okay, like this everything will comes in mood because the patient is telling that thing. So in subjective we can see patient experience emotional state over a period of time. So long term or longitudinal emotional state, for example you can for example if I'm telling means I was sitting sad, so sad will be like mood for 1 month, but today I'm smiling, the smiling coming out, so that is affect. Affect will be like outward, like objective observation. So the effect will be like outward. So you can see like the movement to movement changes in emotional state and external expression of these feelings. So the effect we can see short term and external expression, expressed state outwards. So in effect we can see some types and quality and modality and appropriate and congruent. So first we can see here that is type. In type we can see happy, sad, angry, and anxious and neutral. Next we can see quality. The quality will be like flat, blunt, and constricted or full. Next modality we can see that is like supple, sluggish, and labile. And next we can see appropriate and congruent. So first quality, what it means. The quality will help to understand emotional state at a particular point of time. So in abnormal patients we can see the quality will be like elevation of mood, like in mania and hypomania we can see this type of condition, like the patient will be like euphoric patient, like extreme happiness when failed in exams. This is like abnormal, because if any patient failed in exam means the patient will cry or it will be like sad. But if any person is laughing and they are showing like extreme happiness, then we have to suspect the patient have mania or hypomania. Next we can see elation. Elation means higher step of euphoria, along with that psychomotor activity will be there. So you can see the psychomotor activity means it's not like normal and abnormal, it will be like extreme, like running, jumping, and this type of things the person will do. Next we can see exaltation. In exaltation we can see euphoria, like extreme happiness, along with that increasing psychomotor activity, and we can see delusion of grandiosity. Grandiosity means I know everything, I am the right person. If anyone telling this type of things, we have to suspect the patient have delusion of grandiosity. So next we can see ecstasy. Ecstasy means it's like state of extreme happiness, means epitome of happiness. So these are the things we can see. Next one we can see like dysphoria. Dysphoria means similar to euphoria, like extreme happiness, but mood state is irritability. So in dysphoria we can see in mania patients, example like patient gets irritated at very small things, so that is dysphoria. Next we can see depressed mood. In depressed mood, all the time depressed mood in depression, so the thing will comes in quality depressed mood. So next in effect we can see fluctuations. Fluctuations means from too happy to sad. So the patient will change suddenly. If the patient will laugh, suddenly they will convert into sad. So we call that is labile mood. Labile mood means it's not confirmed that patient is happy or sad. So that thing we comes in labile mood. Like sometimes it will be like happy, sometimes it will be like sad. So that type of fluctuations you can see in patient expression and patient behavior. So it's effective in flattening, flat effect, or emotional blunting and blunt effect. You can see example like you crack a joke, patient does not get angry. You slap him, patient does not get angry. So we have to suspect schizophrenia. That emotion will be like flat. They are not going to give any emotions. If you slap, if you make joke, if everyone is laughing, but that person will be like flat and blunt. They are not going to laugh. So we have to suspect the patient have schizophrenia. Next we can see appropriateness. Appropriateness means it's like relating to situation or external environment. For example, we can see emotional state have to match the external environment. For example, I go to funeral, like burial ground, some funeral is happening in that like social situation. If I'm laughing in that situation, that time it's like inappropriate. So it will comes in inappropriate effect. Next we can see congruence. Congruence means more of an internal comparison, like my emotions are matching with my thought content or not. So example, you can select topic is death of his mother. If patient is giggling, laughing while telling, we have to suspect patient have schizophrenia, because that situation what they are talking based on the situation, that behavior and expressions and effect is not matching. That's why we have to think that patient have schizophrenia. So next we can see that is thought process. Thought process also known as thought form. In thought form, the patient is like open and closed question. So the patient will tell like I know of. If you are seeing the thought process of characteristics, we can see stream flow of thoughts, normal, logical, linear, coherent, and goal directed. So it's speed by which thoughts come to your mind, continuity of thinking. So here in thought process we can say disorganized, tangential, and flight of ideas. So for example, my name is Anand and I'm fifth year medical student. I'm doing clinical rotation in GPHC. So it's coming like step by step. In abnormalities of stream of thoughts, if you're saying means we can see flight of ideas. That means increased speed of thinking. Where in which patient we can see mania problem, if any patient have means we can see in that patient. Next, inhibition of or slowed thinking means slow rate reverse of flighting of ideas. So this thing we can see in depression patients, atypical depression or typical and normal depression patients. Okay, next we can see characteristic abnormalities in schizophrenia like formal thought disorders. First one we can see derailment. Derailment means loss of association between successive thoughts. For example, if any patient have like good association, the patient will lose that thought process and everything. So that thing we call derailment. So in the derailment, if you're seeing here in derailment, the mostly the patient, the thought process will be like it's not linked with successive thoughts. So that thing we call derailment. So another thing we can see loosening of association. Loosening of association means the patient have problem with loss of connections between components of same thoughts. So that thing we call lose of connection between components of thought. That thing we call loosening of association. Next we can see incoherence. Incoherence means word salad. That means the patient will loss of organization. Means the complete what thought the patient want to say, the patient can't say because thus words become salad. Because if you're seeing an example, if you're seeing any salad, we can see different like cucumber, carrot, and beetroot, like that we can see different things, right? So here same to same, no meaning gets conveyed. So that thing we call incoherence. So next we can see circumstantiality. Circumstantiality means it's like if you're asking any question to that patient, the patient will tell like unnecessary things, not directly, but at last the patient will give proper answer, but they will for example, it's like this: show me your nose means directly with your index finger you will show your nose, but in circumstantiality they will round total, then after they will reach nose. So finally goal of thoughts is reached, that is circumstantiality. Next we can see tangentiality. In tangentiality we can see the goal is never reached, it will go somewhere. So if you're asking any question, they will tell unnecessary things, many things, but they are not going to give proper reply what you are asked. Next we can see neologism. Neologism means it's like new words. For example, the schizophrenia patients, if you are asking anything, they will form one word and they will tell like that new word, but you can't understand, but for them it's like one meaning will be there. So that is neologism. Next we can see metonyms. Metonyms means old words, ancient words are used in unconventional strange way. So they are going to use that old ancient words. So that is metonyms. Next we can see clanging. Clanging means sound similar and there may be lack of any meaningful connection. So that is clanging. Next we can see perseveration. Perseveration means it's like repetition of same response beyond point of relevance. That means same answer for every question they will give. If you are asking anything, what's your name, they will tell Anand. from where are you from means they will tell same answer Anand. Like always they will tell same word. If you're asking any question, every question they will give same reply, that is perseveration. Mostly we have to suspect two things like organic brain damage or brain parenchyma or severe psychological problem. Okay, next we can see here, that is thought blocking. Sudden arrest of train of thoughts, leaving a blank. While talking, suddenly they will stop talking, and the thought block, we can tell the things thought blocking. So no thoughts for a period of time, that is thought blocking. So next we can see, that is thought content. What it means? Thought content means what are you thinking about? That means what the patient is thinking. So for example, delusion. Delusion means it's like false belief. How we can delusion, we have one criteria, that is false. 3 steps to diagnose delusion. That is, one is false belief, firm, fixed and unstoppable, like mirror, and unshakable. And we can see unexplained by social, cultural and background. So talking or asking is village people. So these are the things we can see in delusion. Okay, so we have some types of delusion, different types of delusions. So right now we can see, like in delusion, suicidal ideas and obsession, everything will comes in this thought content. So first one, we can see types of delusion. In delusion, we can see delusion of persecution. Persecution means they will think like someone wants to harm that patient. So they will tell like I know some people, they are trying to harm me, they are trying to kill me, like that they will tell. That is that condition, that type of condition we can see schizophrenia. Next we can see delusion of reference. In delusion of reference, we can see like always they will think like that people, okay, that people always they are spying me, they are not believing me because they have some problem with me, like that they will think. So that is the delusion of reference. Next we can see delusion of grandeur or grandiosity. They will think like they have some special power, special role or identity. So these are things they can think. So we can see the type of things in mania or schizophrenia. Next we can see delusion of love. Delusion of love means like erotomania or declare mold syndrome or fantasy lover syndrome. For example, like a hero, heroine, they are sending love letters, or they want to marry her, like that they will think. So that is we called delusion of love. Next we can see delusion of infidelity. Delusion of infidelity means we can see like morbid and jealous and pathological jealous and other syndrome also we can see, that is like cheating. They are not faithful for me, like that they will think. Okay, they are my husband is unfaithful, like that they will think. So for example, if you are seeing means seen in patient with alcohol dependence patients, we can see this type of delusion of infidelity. Next we can see, that is delusion of guilt. Delusion of guilt means severe depression will cause in severe depression we can see delusion of guilt. Next we can see, that is preoccupation. The preoccupation means it will be like somatic preoccupation thought content. Next, some people have some phobias, that thing we call different types of phobias we have. We will discuss in our upcoming videos. Next we can see obsession and compulsions. Obsession compulsion means that is like habit. They will clean, another time they will clean, and they will talk, another time they will tell that things. These are the things will comes in obsession compulsive disorders. We will discuss in our upcoming video because it will be like big topic. Next we can see suicidal and homicidal. Suicidal means they want to kill by themselves. Homicidal means they want to kill someone. So these are things will comes in thought content. So next we can see, that is perception. Perception means in perception we can see any information coming from sensory organs is called perception. So we have in perception we can see like hallucination and illusionation. Hallucination most common in psychiatry department, that is auditory. Hallucination is most common. So we have another hallucination, that thing we called pseudo hallucination. If you are suspecting pseudo hallucination, that must be like we have one criteria, that criteria have to reach. For example, we have 4 steps, that is inner and subjective space. So the pseudo hallucination, that criteria will be like only the patient is able to hear what the person is telling. Okay, and the voices are very clear and voice are middle aged, female, or she keeps talking to me, or voice coming from my mind. I can't stop these voices coming and going. So this type of criteria they will tell, this type of things they will tell. So we have to suspect patient have pseudo hallucination. Next, another type of hallucination we have, that is reflex hallucination. Reflex hallucination means the patient will hear the light, the patient will see the music. So we have to ask stimuli of hallucination. So these are the things we can see. Okay. Next we can see that is cognition. Cognition means level of conscious and orientation with time, place, person, and we can see attention and concentration. Next we can see memory. In memory you can see like immediate memory, working memory, and recent memory, and remote memory. So we can see in remote memory you can see dementia and lost in the last. Okay. So next you can see abstract thinking. Abstract thinking means, example, a stylus, a stitch in times saves 9. So in normal cases people will think like saving a problem early prevents bigger problems later. So if you're seeing concrete, the stitching plans quickly saves thread. So in example, the thought, the cognition will change, the abstracted thinking will change. So in schizophrenia and dementia we can see concurrent thinking. So next we can see here, that is insight. Insight means awareness of illness. So the patient is aware, awareness and understanding of their illness. So that thing we call insight. In insight we have total 6 different types of grades. So based on that we have to give grade point for patient. So in grade 1 we can see complete denial of illness. So the patient will think like the patient don't have any illness, the family members brought me here, like that they will give complaint. So next we can see grade 2, that is slight awareness but denies need for treatment. Next we can see grade 3, that is aware of illness but blames external factors. Next we can see grade 4, that is recognizes illness but doesn't fully understand. Next grade 5 will be like intellectual insight. In grade 6 we can see true emotional insight. So at last we can see judgment. This is the main judgment, will help to like social judgment, and it will test judgment. So example, fire in cinema hall, what they are going to do. So that is hypothetical questions we have to ask. In judgment, the patient ability to make appropriate decisions in daily life and tested with hypothetical situations. So these are the things will comes in mental status examination. So we already covered everything step by step. Then after, based on this mental status examination, we have to apply into that DSM-5 criteria. So if MSE is part of all psychiatric diagnosis, the DSM-5 and ICD-11 is a approach. So no single criteria based on symptoms clusters and identified via mental status examination. So we covered everything like properly with examples. That is, what are the things we can see in mental status examination? That is appearance, behavior, emotions like mood and affect, speech and thought process and thought content. And next we can see perception, cognition, and insight and judgment. Okay, so if you didn't subscribe my channel, please like, share and subscribe. If you have any doubt, you can ask me in comment section. We will meet in our next psychological series. So till the time, I'm signing off. Take care. Bye bye.